if you break a bone, an X-ray gives you a clean, like, binary answer.
Right.
It's broken or it's not.
Right, it's basically engineering at that point.
Yeah, exactly. The doctor just, points to a jagged white line on a glowing screen and tells you exactly what happened.
Yeah.
But if your body's primary biological filter, which is the kidney, starts to fail, well, that X-ray machine is entirely useless.
Oh, totally useless. You can't see the problem.
Right. You're left staring into these like microscopic, diagnostic, murky waters. And you're really just trying to answer one critical question, which is the filter leaking or is it bleeding?
And I mean, understanding the difference between that leak and that bleed is basically the entire foundation of modern nephrology. We like things in medicine to be visible and easily categorized.
Oh, for sure. Put it in a neat little box.
Exactly. But the kidney's architecture, it forces us to look at cellular mechanics that we can't even see with a standard microscope.
Which is wild.
Yeah.
So welcome to the deep dive. Today we've got a really dense stack of medical sources outlining kidney pathophysiology. And our mission for you, the listener, is to untangle two massive concepts that govern this organ, which are nephrotic and nephritic syndromes.
It's a huge topic.
It really is. So we are going to look at how glomerular disease fundamentally alters your urine, how these microscopic failures actually happen, and, why this tiny machinery matters so much to your overall health.
Okay, let's unpack this. How did we even figure out there was a filter problem in the first place, back before we had any of this microscopic imaging?
Right, so to get that, we have to travel back to 1827.
Okay, quite a ways back.
Yeah. There was a physician named Richard Bright working at Guy's Hospital in London, and he started noticing a very specific pattern in his patients. He basically correlated three distinct clinical signs.
Which were?
Well, first was dropsy, which was the 19th century term for severe widespread swelling or edema. Second was the presence of albumin, which is a major blood protein.
Right in the urine, right? Exactly, appearing right in the urine. And third, when he performed autopsies on these patients after they died, he consistently observed these scarred, shrunken kidneys.
Wow. So he's putting the puzzle pieces together purely from observation. I mean, he doesn't know what a podocyte is. He just sees swelling protein in a damaged organ on the autopsy table.
Yeah, Bright was reasoning entirely from bedside symptoms and post-mortem pathology. So for nearly a century, medical science just lumped this entire family of kidney diseases together under one huge umbrella term, which they called Bright's disease.
Classic medical history move.
Oh, totally.
Name a dozen different complex microscopic problems after one guy, just because they all vaguely look the same from the outside.
Pretty much. The assumption was, if the kidney was failing and the patient was swelling, it was all the same fundamental illness.
Right. So when did they figure out it wasn't?
It actually took until 1905. A German pathologist named Friedrich von Müller realized this wasn't a single disease process. Pathologists looking at tissue samples noticed this really stark divide. Some failing kidneys showed heavy inflammation.
Like immune cells everywhere.
Yeah, just swarming with immune cells, structural tearing, a real mess. But other kidneys, the ones losing massive amounts of protein, they looked completely bland.
Oh, interesting. So no inflammation.
Right, no inflammatory cells at all. The tissue just looked degenerative. So von Müller coined the term nephrosis to describe that non-inflammatory degenerative damage.
Okay, to separate it from the inflammatory stuff.
Exactly. He used it to separate it from nephritis, which denoted an actively inflamed kidney.
Okay, got it. So nephrosis becomes the leak, and nephritis becomes the inflamed, bleeding filter. But to really grasp this, we need to picture the filter itself.
It helps to have a visual, yeah.
I always think of the healthy glomerulus, the microscopic filtering unit of the kidney, like a perfectly calibrated 3-layer coffee filter.
That's a really good analogy, actually.
Yeah. So first you have the fenestrated endothelium, which is basically a cellular layer full of tiny windows. Second, the glomerular basement membrane, or GBM, acting like the thick, fibrous paper of the filter.
Right.
And third, on the outside, you have these highly specialized cells called podocytes, and they literally have little microscopic foot processes that interlock with each other, forming extremely tight slit diaphragms.
Like interlaced fingers.
Yes, exactly. So water and small toxins slip right through those slips to become urine, but the big stuff, like red blood cells and massive proteins like albumin, they get held back in the bloodstream.
And which of those specific layers gets damaged dictates entirely whether a patient develops a nephrotic or a nephritic syndrome.
Okay, so break that down for us.
Well, in nephrotic syndrome, which is the leaky filter, the damage is heavily concentrated on those podocytes you mentioned. The intricate foot processes, they flatten out and lose their interlocking structure.
Oh, wow.
Yeah, so the barrier becomes compromised, allowing large molecules to slip through. But crucially, the filter is not physically torn apart.
It's just stretched.
Exactly. And it is not swarming with inflammatory immune cells.
So the coffee filter hasn't ripped. The microscopic pores have just, stretched too wide.
Right. Because the structure isn't torn, the red blood cells stay in the bloodstream where they belong. But protein, specifically albumin, pours right through that stretched out filter into the urine.
And that causes problems.
Big problems. This triggers the classic clinical tetrad of nephrotic syndrome. Patients present with heavy proteinuria, losing more than 3.5 grams of protein a day.
Wow, that's a lot.
It is. And that causes hypoalbuminemia, which is a severe drop of protein in the blood. And without that protein in the blood to exert osmotic pressure and hold on to water, fluid shifts out of the blood vessels and into the soft tissues.
Which causes the massive edema, or the swelling.
You got it. And finally, the fourth part of the tetrad is hyperlipidemia, or high cholesterol.
Okay, wait. I get why a leaky filter causes protein loss. And the fluid shift makes perfect sense for the swelling. But hyperlipidemia, why on earth is the body producing high cholesterol in response to a kidney leak?
It sounds crazy,
It
right?
feels completely disconnected from the kidneys.
It looks random on the surface, but it's really an act of metabolic desperation. Your liver acts as the body's protein factory. It senses that the blood is dangerously low on albumin because, well, it's all vanishing into the urine.
Right.
So the liver goes into absolute overdrive, spinning up its manufacturing pathways to replace the lost protein. The catch is that the liver's synthetic pathways are intrinsically linked.
Oh, I see where this is going.
Yeah, as it cranks out new proteins, it simultaneously cranks out lipoproteins, which are the carriers of cholesterol. The liver is desperately trying to fix a protein deficit, and the unavoidable side effect is that the patient's blood lipids just skyrocket.
Okay, that makes so much sense now. So if nephrotic syndrome is this quiet, invisible leak caused by flattened podocytes, what does it take to actually rip the filter enough to let something as massive as a red blood cell squeeze through?
Well, that brings us to nephritic syndrome, the inflamed bleeding filter. Here, the capillary wall itself is under direct attack.
A physical attack.
Yes, immune complexes deposit in the tissue, triggering aggressive inflammation. White blood cells swarm the area, releasing all these destructive enzymes. The structural integrity of the filter is actively disrupted and torn.
So now the coffee filter actually has a rip in it and the grounds are spilling through.
Exactly.
Yeah.
Because of that structural tearing, red blood cells leak directly into the urine, which causes hematuria. You also see hypertension, or high blood pressure, and oliguria, which is a dangerous drop in urine output.
Wait, a drop? Why does it drop?
Well, the filter becomes so clogged with inflammatory cells and debris that it simply stops letting fluid through.
Oh, wow. It's totally jammed.
Right. So waste products like BUN and creatinine begin building up rapidly in the blood, which is a condition called azotemia. You do see some protein in the urine because the filter is damaged, but usually nowhere near the massive quantities seen in a pure nephrotic leak.
Getting from the abstract definitions to real patients is where the sources get really fascinating.
Yeah.
Let's look at how this pure leak actually manifests. Minimal change disease, or MCD, is the most common cause of childhood nephrotic syndrome. And it presents this bizarre diagnostic paradox.
It really does.
Like you have a child who's massively swollen, losing grams of protein a day. But when a doctor takes a biopsy of their kidney and looks at it under a standard light microscope, the kidney looks absolutely pristine.
Totally normal.
Right. How can the symptoms be so severe, but the physical hardware looks completely fine?
It comes down to the equipment. The light microscope simply lacks the resolution to see the structural failure. It's like trying to see a cracked microchip with a magnifying glass.
Yeah.
The damage is profound, but it is invisible at that specific magnification, which is why it earned the somewhat misleading name minimal change. To see the true lesion, pathologists have to use an electron microscope, magnifying the tissue tens of thousands of times.
And what do they see then?
Only then do you see the diffuse effacement of the podocytes. The intricate, interlocking foot processes have completely collapsed and melted into a flat, featureless sheet.
The cellular architecture has literally collapsed at the nanoscale. That is crazy. But the historical treatment for this is just as fascinating as the pathology.
Definitely. Before the 1950s, a child developing massive swelling from MCD faced a really grim prognosis. The mortality rate was substantial, driven largely by severe infections and catastrophic blood clots caused by losing key proteins in the urine.
But then something changed.
Yes. The introduction of corticosteroid therapy changed everything. It turned MCD into a disease with an excellent prognosis for the vast majority of pediatric patients.
But how do steroids actually fix a collapsed architectural structure? I mean, steroids just suppress the immune system, right? How does that rebuild the podocyte's tiny feet?
Well, that was the assumption for decades, that steroids just quieted down some unknown immune factor circulating in the blood. But modern research suggests corticosteroids actually have a direct non-immune effect on the podocytes themselves.
Really? How so?
The steroids interact with the podocyte's internal scaffolding, its actin cytoskeleton, essentially signaling the cell to stabilize its structure and physically rebuild those complex foot processes.
So we are chemically forcing the cell to repair its own architecture.
Exactly.
Wow, so MCD is this quiet, almost invisible collapse. On the complete opposite end of the spectrum is post-streptococcal glomerulonephritis, or PSGN. This is the textbook nephritic story, a loud, violent, bleeding filter.
Oh, absolutely. The clinical presentation is unmistakable. A child comes down with a standard strep throat or a skin infection like impetigo.
Pretty common kid stuff.
Right. They recover. But 1 to 3 weeks later, long after the bacteria is cleared, they suddenly develop puffy eyes, their blood pressure spikes, and their urine turns the dark color of cola.
The time lag is the major clue there, right? The infection is basically gone, but the kidneys suddenly fail weeks later. Why the delay?
The delay tells us that the strep bacteria isn't attacking the kidney directly. The real culprit is the immune system's memory. When the child was sick, their immune system manufactured antibodies specifically designed to bind to the strep antigens.
Okay, normal immune response.
Right. These antibodies and antigens lock together, forming microscopic clumps called immune complexes. These complexes float harmlessly in the blood for a while, but eventually they circulate through the tiny, high-pressure capillaries of the kidney's glomerulus and they physically lodge in the filter.
Like debris slowly clogging up a drain until the pipe bursts.
Exactly like that. Once those immune clumps lodge in the tissue, they trigger the complement system. You can think of the complement system as a domino effect of immune alarm bells. It's a cascade of proteins that aggressively calls in inflammatory cells to destroy whatever triggered the alarm. In PSGN, these lodged complexes consume a specific complement protein called C3 right there in the kidney.
So if you test the blood,
If you run a blood test during this acute phase, the patient's circulating C3 levels will be remarkably low because it's all being used up to fuel the inflammation in the glomerulus. The kidney is basically suffering massive collateral damage from an immune system that is doing its job a little too well.
here's where it gets really interesting. When we talk about immune attacks, we have to look at membranous nephropathy. This is a major cause of the leaky nephrotic syndrome in adults. For decades, doctors only knew it as a descriptive diagnosis. A biopsy showed a thickened basement membrane, but nobody knew exactly what was forcing it to thicken.
Right. Nephrologists were essentially treating a shadow. They knew the membrane was reacting to some sort of immune deposit, but the exact target was a complete mystery.
Then a massive breakthrough happens in 2009, published in the New England Journal of Medicine. Researchers discovered that a huge percentage of these patients were making autoantibodies against a very specific receptor on their own podocytes, a target called PLA2R.
Yeah. Identifying the M-type phospholipase A2 receptor fundamentally changed how we manage the disease.
How is it different from the strep one we just talked about?
Well, it's crucial to understand how this differs from PSGN. In PSGN, random clumps of immune debris get physically stuck in the filter. But in membranous nephropathy, this PLA2R autoantibody is seeking out a specific receptor that lives exclusively on the bottom of the podocyte.
Oh, it's targeted.
Highly targeted. It binds directly to the podocyte, forming local immune deposits. The basement membrane reacts to these toxic deposits by trying to swallow them up, building extrastructural material around them, which is what causes the profound thickening seen on biopsies.
And because we know the exact molecular target now, you no longer have to stab a biopsy needle into someone's kidney every 6 months to see if the disease is active. You can just draw their blood, measure the anti-PLA2R antibody titers, and literally watch the autoimmune disease rise and fall in real time as you adjust their medication.
Which is incredible.
It's a brilliant pivot
Yeah.
from a vague anatomical description to a precise, molecularly targeted blood test.
Absolutely. Moving from descriptive pathology to a measurable molecular mechanism is the ultimate goal for every disease in nephrology.
We've laid out these textbook examples, the leaky podocyte in MCD, the inflamed capillary in PSGN, but the sources highlight a major point of tension in the field, which is that human biology rarely respects the neat, categorized boxes we put in textbooks.
No, it definitely doesn't. The traditional divide between nephrotic and nephritic is incredibly useful for teaching medical students, but modern nephrologists view these syndromes as overlapping axes on a spectrum.
Okay, a spectrum.
Yeah, you have one axis for membrane leakiness and one axis for cellular inflammation. In the real world, diseases routinely push patients along both axes simultaneously.
So a patient can have massive nephrotic level protein loss while actively bleeding and showing nephritic inflammation at the exact same time?
Exactly. Diseases like severe lupus nephritis, membranoproliferative glomerulonephritis, or MPGN, and IgA nephropathy do this constantly.
Wow.
A patient with IgA nephropathy might show up with the classic nephritic symptom of visible blood in their urine after a respiratory infection. But as the disease chronically damages the filter over years, they can develop massive nephrotic range proteinuria. They occupy both categories.
Treating these diseases like simple either-or boxes isn't just confusing, it can be dangerous. Which brings us to focal segmental glomerulosclerosis, or FSGS.
Yes, a tough one.
This disease perfectly illustrates the terrifying reality of sampling error in diagnostics. So FSGS causes aggressive scarring in the kidney, but the scarring is patchy. It is focal, meaning it only affects some glomeruli, and segmental, meaning it only affects parts of those individual filters.
Right.
A doctor can insert a biopsy needle, pull out a core of tissue, and completely miss the scarred areas by mere millimeters.
And that's the danger. If the pathologist only looks at the healthy-seeming glomeruli that were captured in the sample, they will put it under the electron microscope and see diffuse podocyte effacement. Without seeing the scar tissue, it looks identical to minimal change disease.
And the consequence of that miss is massive. You tell an adult patient they have MCD, hand them a prescription for high-dose steroids, and assume they'll recover. But FSGS is notoriously steroid-resistant.
Right.
The treatment fails, and the patient slowly progresses toward end-stage kidney failure while everyone thinks they are treating a highly responsive disease.
It highlights why careful histologic sampling is so vital. But FSGS is also at the center of a monumental genetic discovery. If we connect the bigger picture, we have to talk about the APL1 gene variant, which completely reshaped our understanding of kidney disease demographics.
Wait, so an ancient defense mechanism that saved humans from a parasite thousands of years ago is the exact same thing destroying their kidneys today? That is a brutal evolutionary trade-off. Let's dig into how that actually happened.
So researchers noticed that rates of FSGS and hypertensive kidney disease were drastically higher in people of West African ancestry.
Okay.
When they mapped the genetics, they found variants in the APL1 gene. Thousands of years ago, in regions of Africa, populations were devastated by the trypanosome parasite, which is transmitted by the tsetse fly and causes African sleeping sickness, a highly fatal disease.
The evolutionary pressure to survive that parasite must have been immense.
It was absolute survival of the fittest. A random mutation occurred in the APL1 gene. This mutated gene produced a specialized protein that circulated in the blood, and when the trypanosome parasite entered the body, this protein literally popped the parasite open, killing it.
Wow.
Carrying this variant provided an incredible survival advantage. Those individuals lived, reproduced, and passed the gene on, but modern science revealed the devastating hidden cost.
The trade-off.
Right. In our current environment, producing that highly active APL1 protein inherently stresses and injures the kidney's podocytes over a lifetime, massively increasing the risk of FSGS.
It is a profound example of how our ancient environments still dictate our biology. The evolutionary ghosts are still pulling the levers in our modern organs. Speaking of ghosts, the sources bring up the ghost of historical naming failures. Goodpasture syndrome.
Oh, yeah.
Ernest Goodpasture coined the term after the 1918 flu pandemic, and for decades, doctors used it as a catch-all for anyone coughing up blood from their lungs while simultaneously bleeding into their urine.
It was a clinical description of symptoms, not a disease mechanism. It took modern antibody testing to realize that Goodpasture syndrome was actually lumping together entirely different diseases that just happened to attack the same two organs.
So they were totally different things.
Completely. Today, we know true anti-GBM disease is caused by autoantibodies directly attacking the collagen in the basement membranes of both the lungs and the kidneys. But another disease, ANCA-associated vasculitis, can look clinically identical, lung hemorrhage and kidney failure, but the immune mechanism is completely different and requires a different treatment protocol.
It's like calling every single car problem a broken engine, until someone finally invents the diagnostic computer to see that one is a busted spark plug and the other is a cracked fuel line.
That's exactly what it was like.
Because these overlapping syndromes are so microscopically complex, people carry around a lot of misconceptions. Let's clear some of these up because they reveal the real-world stakes of this microscopic anatomy. For instance, people often assume that if there is blood in the urine, it must be a bladder stone or a standard urinary tract infection.
A very reasonable assumption, but entirely incorrect when dealing with glomerular disease. Blood coming from the kidneys filter, glomerular hematuria, leaves a highly specific microscopic fingerprint that a trained nephrologist can spot instantly.
The red blood cells don't look like normal, healthy cells from a fresh cut, do they?
No, they are dysmorphic. They have been brutally squeezed, battered, and distorted as they were forced through the tight, inflamed gaps in the glomerulus and pushed down the narrow tubules of the nephron.
Yikes.
They frequently clump together with proteins to form red cell casts, which are literal microscopic molds of the kidney's tubules. Furthermore, because the blood has been chemically altered by the acidic environment of the nephron during its journey, the urine doesn't look bright red. It looks dark brown, like tea or cola.
Oh, wow.
That visual and microscopic fingerprint proves the bleeding is high up in the delicate filter, not down in the bladder.
There's also this dangerous misconception that a pure nephrotic syndrome is somehow mild because it's, quote-unquote, just a protein leak, without the scary-sounding inflammation or kidney failure. People might think, oh, I'm losing protein, I'll just eat a large steak and replace the calories. But they aren't just losing nutritional protein, right? They are bleeding out highly specialized biological tools.
A massive protein leak is inherently dangerous. For instance, nephrotic patients lose antithrombin III in their urine.
And what does that do?
This is a crucial regulatory protein that prevents your blood from clotting unnecessarily. When you pee out your antithrombin III, you enter a severe hypercoagulable state. These patients are at a massive risk for spontaneous, life-threatening blood clots, particularly in the deep veins of the legs or the renal vein itself.
So they are literally bleeding out the very protein that stops them from clotting to death.
Furthermore, they lose immunoglobulins, their circulating antibodies. Without those, the immune system is severely crippled. Historically, before the invention of broad-spectrum antibiotics, simple bacterial infections were a leading cause of death in children who developed nephrotic syndrome.
Which naturally leads to the assumption that if you have nephrotic syndrome and you're swelling up, your kidney must have completely stopped filtering altogether.
Which is also false. Early on in a purely nephrotic disease, the overall filtration rate, the glomerular filtration rate, or GFR, might be totally normal.
Really?
Yeah, the raw volume of fluid moving through the organ isn't the problem. The danger is what is escaping in that volume. The podocyte barrier is leaky, but the plumbing is wide open.
Okay, got it.
Nephritic syndrome, by contrast with its aggressive cellular inflammation and swelling, physically clogs the pipes. It directly threatens the GFR and pushes the patient toward acute kidney failure much earlier in the disease process.
And the global stakes for understanding these mechanisms are massive.
Huge. Diabetic nephropathy is the leading cause of end-stage kidney disease in high-income countries, and it operates primarily as a nephrotic pattern leak. Chronic high blood sugar causes advanced glycation end products, essentially turning the proteins in the kidney's filter sticky.
Oh, that sounds bad.
It is. They cross-link and form dense, round nodules of scar tissue known as Kimmel-Steele-Wilson lesions. The delicate filter is replaced by hard, useless nodules, leading to massive protein loss. It tracks perfectly with the global diabetes epidemic.
And what about the inflammatory side?
Meanwhile, post-streptococcal glomerulonephritis remains a stark marker of health system disparities, devastating populations in areas of the world that lack reliable access to early antibiotic treatment for simple infections.
So what does this all mean? We've gone from 19th century observational autopsies to advanced electron microscopes, unraveling ancient genetic evolutionary trade-offs along the way. The big takeaway for you listening is that the kidneys aren't just passive plumbing pipes. They are highly dynamic, incredibly vulnerable cellular barriers.
Yeah.
Whether an autoimmune disease targets the podocytes to cause a massive invisible protein leak, or circulating immune clumps inflame the capillary wall to cause a bloody, clogged backup, the resulting syndromes tell us a profound story about how the human body attempts to maintain its balance.
And sometimes, the body's hardwired attempt to save itself is exactly what accelerates its own destruction.
How so?
I want to leave you with a final thought to ponder regarding the renin-angiotensin-aldosterone system, or RAS, which is the body's primary blood pressure control mechanism.
The system that manages how hard the blood is pumping.
Exactly. When a nephritic kidney becomes severely inflamed and clogged with immune cells, its local filtration rate drops. The kidney panics. It senses that not enough fluid is moving through its tubules, so it triggers the RAAS cascade to purposefully drive up the body's systemic blood pressure. It is desperately trying to force more fluid through the failing filter to keep clearing toxins.
Wait, it's actively raising systemic blood pressure to push fluid through a microscopic filter that is already inflamed and bleeding.
Consider the physics of that. The kidney is relying on an ancient, hardwired survival mechanism to maintain its filtration rate at all costs. But by driving up the blood pressure, it is hammering the very capillaries that are already physically torn and damaged with high-pressure blood flow.
That is wild.
It raises a deeply provocative question in the context of acute glomerular disease. Is the kidney's desperate survival mechanism actually the very thing sealing its fate?
It's like turning a high-pressure fire hose on a cracked window to try and clean the glass. It just shatters the structure completely. And suddenly that X-ray machine we talked about at the beginning seems entirely inadequate. You can't take a simple snapshot of a paradox like that. You have to look deeply into the murky waters, understand the unseen cellular mechanisms, and figure out if the filter is leaking or bleeding. Thanks for joining us on this deep dive. We'll catch you next time.